Our moderator for this session will be Dr. Radhika Datta. She is currently posted as the tutor in Institute of Postgraduate Medical Education and Research. She has several award papers and researches to her name, and she takes keen interest in clinical dermatology, dermatopathology, leprosy, and clinical research. Over to you, madam.
Thank you, Shairi, for the kind introduction. Okay, welcome you all to this session on leg ulcers. First, we have a session on clinical approach to leg ulcers by Colonel Biju Vasudevan. Sir is editor-in-chief of Medical Journal of Armed Forces India and has been the Joint Secretary of IADVIL in 2016. Sir has edited 7 textbooks and has over 100 publications to his name. His special areas of interest are connective tissue diseases, deep fungal infections, and also quizzing. Sir, over to you, sir. Dr. Biju, sir.
Yeah, are my slides visible?
Yes, sir, they are visible, sir.
Yes, thank you so much, West Bengal, for inviting me, and it's always a pleasure to be among the, as the Bengalis are called, the elite dermatologists. Yes, so my topic for today is the clinical approach to a case of leg ulcer, because the management aspect will be discussed in the panel discussion. So basically, an ulcer is nothing but a discontinuity of the skin or mucous membrane, which occurs due to the microscopic death of the tissue. That means necrosis. So usually it takes 4 weeks to heal, though some say traumatic ulcers may heal a bit early. And if it goes beyond 6 weeks, that is when we say that it's a chronic leg ulcer. So what is the importance of the topic? Basically, it can occur in any age, though the above 65 are much more affected. There is increasing incidence in the last few decades. They have varying etiology with complicated systemic diseases associated with them. So treatment may be difficult. Considerable morbidity can occur and can lead at times to life-threatening complications. So the common causes, as we can see, the venous and the arterial causes are the commonest, along with the neuropathic, especially the diabetic and the leprosy. You can have traumatic ulcers also being very common, other than infections and vasculitis. Other neurogenic causes, tropical ulcers, post-thrombotic ones, the malignant, the drugs causing ulcers, and are comparatively much more uncommon. Rare causes like martorells, that's in hypertension, Melanese, that's a synergistic gangrene, can also occur. So how do you approach a case of leg ulcer? So basically, you take a good history. What is the mode of onset, like if it is acute, following a trauma, if it is occurred spontaneously, if it is occurred following exposure to cold. So these are things which basically add on to what is the etiology. Acute and chronic, we've already discussed. If there's pain, of course, you think like something like a arterial ulcer, a hypertensive ulcer. You don't think of a venous ulcer unless it's really secondly infected. Discharge much more common with a venous kind of ulcer. And of course, you take history regarding the associated disease, especially important for us, the leprosy, diabetes, and also sometimes syphilis can also give rise to these lesions. When you inspect the lesion, you basically look at the size and the shape of the ulcer, the number of the ulcers. As we go by the Das's principles of internal surgery, I'm sure all of us have read it in our MBBS, position of the ulcers, the edge of the ulcer, whether it's undermined, whether it's punched out as in case of arterial or sometimes the neuropathic ones, whether you have the violaceous margins as in pyoderma gangrenosum. You look at the floor, how clean it is, whether there's any discharge which is there, is it filled up with granulation tissue, how is the surrounding area. Also examine the limb for say any varicosity is present. So these will help us basically let us know the etiology. And you palpate for tenderness, the margins, the base, whether it is fixed, what is the depth of the ulcer, is there bleeding, what is the relation to the, so it's fixity, then you should think of malignancy also as a cause, mobility of the ulcer and the surrounding area. All these you'll not only inspect, you'll also palpate. Along with that, you also need to do some general examination like examination of the lymph nodes, vasculature. We'll come to the ankle brachial pressure index. You examine the nerves, you look at joints, And various other aspects of the general examination like pallor, edema, these also contribute to your etiological diagnosis and also to prognosticate the case. So as I said earlier, so in history and examination, so onset of the ulcer, the symptoms, any risk factors, any aggravating factors, the underlying medical history, the family history, any medications, and things like smoking can worsen the arterial ulcers or maybe a cause itself. This we've already discussed the physical examination. I just wanted to put the history and the examination together here. You can also look at the peripheral pulses, of course, especially important for arterial causes, capillary refill time, and also deep tendon reflexes when it comes to the neuropathic ulcers. So the ankle brachial pressure index is basically nothing but the highest systolic ankle pressure by the highest systolic brachial pressure. Very important to distinguish, especially between arterial and venous ulcers. So you basically take the systolic ankle pressure that you do for the dorsalis pedis or the posterior tibial, and then you take the brachial artery basically pressure there, and then the ratio of it. So if it is less than 0.8, it means it's arterial. And if it's less than 0.5, that means urgent treatment is required. Whereas if it is more than 1, it is usually venous. So we'll be describing some of the common causes so that we know what are the clinical presentations of these ulcers. So first, coming to the arterial ulcer, as we all know, risk factors could be smoking. It can present with intermittent claudication. So even in diabetes, actually, you can have the arterial cause predominant in cases. Then you have atherosclerosis, of course, a common cause too. So usually the toes and the distalmost part of the extremities are affected. The pain is going to be there in this kind of ulcer. It could be severe at night and it's going to be relieved by dependency. Major distinguishing factor when it comes to arterial from the venous ulcers. Also, when you look at the morphology of the ulcers, there would be dry necrotic base, punched out edges compared to the irregular edges of the venous. Surrounding inflammation is usually absent, and you can have a paleness to the ulcer. You can have certain trophic changes. You can have loss of the hair as like trophic ulcers. This is because of the loss of vascularity. Absence of pulses, of course, definitely points to an arterial ulcer. Prolonged capillary refill, another important factor. And as I said, ABI, less than 8 could be arterial. Less than 0.5, you need to act urgently. So it's 10 to 30% of all ulcers. Various studies give various other incidences, but general incidence percentage is about that much. Poor peripheral circulation is a cause. Could also be due to trauma. So these are some of the common causes: Berger's, atherosclerotic disease, vasospastic conditions, the hypertensive ulcer. It also the diabetes, smoking, hyperlipidemia, hypertension, obesity, and increased age can add to it. Occlusive involvement can also occur. Now coming to the venous ulcer. Now, venous ulcer, we know the commonest cause is varicosity. You can have it following thrombosis. You can also have it in multiple pregnancies also. That's the when you go to the thrombotic venous disorders. The usual symptom is aching or swelling at the worst of day, which is relieved by elevation. The gaiter area is the most common involved, basically the medial malleolus, or could be between the malleolus and the lower calf. There would definitely be some oozing in most of these ulcers initially before treatment. And as we see, they are irregular ulcers. They could be flat or steep elevation to the margins, usually associated with a heavy exudate and surrounding inflammation. If you look at the surrounding skin, you may get the etiological causes, like if you have lipodermatosclerosis, then you have edema, then you have the normal capillary time and normal ABI. These actually add on to your diagnostic findings. So what is the site, as we've already discussed? Importantly, if there's a long saphenous varicosity, you get it on the medial side of the leg, whereas if the short saphenous varicosity, you get on the lateral side of the leg. Usually such ulcers are not seen above the junction of the middle and the upper third of legs. So this is a venous ulcer. You can see the lipodermatosclerotic changes around it. Same. Now come to the neurotrophic ulcers. Now very common in our specialty. We see them in leprosy. We also see in diabetes and rarely in syphilis too. So you can get paresthesias, numbness, loss of sensation. You can also get these ulcers on the under the calluses or the pressure points. Usually there's no pain. The characteristics of the arterial ulcer, like the punched out, are not available. The surrounding inflammation is present, and you can get demonstrable neuropathy. So the common causes, as I said, diabetes and leprosy. You can have alcoholic neuropathy, nerve injuries, paraplegia, stapes dorsalis. The malnutrition, neurological deficits, of course, add on to it. Coming to the vasculitic ulcers seen in vasculitis or in connective tissue disorders, usually the pretibial area and the dorsum of foot are involved, though other areas may also be. They are extremely painful. They can have hemorrhagic vesicles, okay, and they can have an indurated base. The pathology could be present, especially if Behçet's-like ulcers, and surrounding inflammation may be present. Coming to traumatic ulcers. Now, these are ulcers which we usually do not consider as a huge cause, but they are quite the common causes, especially on the shin and the malleoli. In fact, there are interesting, the footballer's ulcer, which is found on the shin, which can get recurrently infected with staphylococci and even can go on to become osteomyelitis. Hypertensive ulcers is a characteristic ulcer. The Martorell's ulcer, the lateral malleoli is commonly affected. You can have black necrosis with surrounding inflammation. Pyoderma gangrenosum, we all know. Basically, it can be of various types. The pain is going to be severe. You can have a bluish undermined border to this. That is what is characteristic. And of course, it can be having its various associations like IBD and Behçet's, also myeloma and leukemia. Pernio is nothing but exposure to cold, which can lead rise to nodules, vesicles also certain times, and ulceration. So usually you get it on the tip of the toes. They basically are small and multiple ulcers. That is how they are usually present. You can see this case here where there's almost like a kind of the increase in vascularity which is seen there. You can see the erythema here, which is characteristic. The livedo reticularis, you have a net-like pattern. You can have nodules again with ulcers. The lower part of the leg or around the ankles are most commonly involved. And here it is basically occlusion. So it is a occlusion of the small vessels. No, it's not a vasculitis. It is a occlusion which manifests with livedo reticularis. You can see here the livedo on the leg. Clotting disorders like venous thrombosis, antiphospholipid syndrome, these are also causes for ulcers. And you can have vasculitis with the clotting disorders as in factor V Leiden deficiency too. Antiphospholipid syndrome and can, of course, with the thrombosis can lead to rise to ulcers. Can also have the livedo, something like a livedo reticularis. Tropical ulcers, usually caused by the Vincent's organisms, can be rarely found on the legs too. So predisposing factors, malnutrition, the poor immunity. It can follow trauma or insect bites. Starts as papules and can have lymphadenitis. The papules can progress to pustules. You can have lymphadenopathy. You can have a copious discharge, and it can be complicated by squamous cell carcinoma. This is another condition which you are familiar with, that is necrobiasis lipoidica. You associate with diabetes mellitus or otherwise too. You have palisading granulomas, and it is usually present symmetrically on the middle of the shins. So you have telangiectatic vessels which are present on the lesions before ulceration. That's how you identify them. There are various neoplastic causes too. You can see that all lymphomas, leukemias, malignant melanomas, all can lead to the neoplastic ulcers on the legs. So to sum it up, basically, when you have a leg ulcer, do a history physical examination. You can divide it into painful and painless ulcers. Painful ulcers, you know, mostly arterial here. So you need to do an arteriography. You have the associated findings. You have the causes for them. Your painless ulcer, you look at venous ulcers predominantly. You can do an ultrasound. You can also do a biopsy if required to have the cause for it. And if you have a normal vasculature, that is, you don't have a venous and an arterial, then you look at the neurotropic ulcers where you have the paresthesias and the numbness. Then you have the other causes like infectious ulcers. You have chronic ulceration with elevated edges. You do think of neoplastic. History of trauma, of course, you look at the traumatic ulcers. So this will be in a nutshell how you look at the clinical approach to leg ulcer. And the three most common ones, the venous, arterial, neuropathy, can differentiate like location of the ulcer, medial malleolus here, the distal toes here, pressure sites for neuropathic. Morphology, it's going to be punched out in case of arterial and neuropathic. Surrounding skin, definitely in venous, you'll have more symptoms and findings. And the other associated like edema, the capillary refill time, the ankle brachial pressure index helps us to differentiate the different kinds of ulcers. So to conclude, ulceration of the leg is a frequent disease. It causes pain, social discomfort, a lot of cost to the patient. It's quite a common disorder. We need to have a rational approach with not only a detailed knowledge of the clinical picture and the pathogenesis, also consider a lot of diagnostic possibilities And we should be aware of the large differential diagnosis to rule out important causes like the arterial, the venous, and the neuropathic, and then come to a final diagnosis before we can go on to management. So these are my references, and thanking all of you for this opportunity.
Thank you, sir. Thank you, Viju, sir, for that enlightening session. So without further ado, I would like to move on to the panel discussion. So for our panel today, we have, of course, we have Biju sir. We also have Dr. Shumit Sen, Professor at Institute of Postgraduate Medical Education and Research, Professor Siddhartha Das, Professor at Vivekananda Institute of Medical Sciences, Dr. Tanushri Shorkar, Associate Professor at Bardhaman Medical College, and last but not the least, Dr. Anupam Dash, Assistant Professor at KPC Medical College, Kolkata. So, sir did a very extensive presentation on how to clinically approach the leg ulcers. Leg ulcer, as we know with its varied etiology, is too vast a topic to be covered in such a short duration. Now, I sincerely apologize to all my panelists beforehand because I won't be able to ask each of you all the questions. So since venous ulcers, as we know, comprises nearly 70% of the leg ulcers, I would first start with a case like that. He's a 57-year-old gentleman presenting with such ulcers since the last 1.5 years. These are painless, and he also gives a history of prolonged standing. Venous Doppler was done with a saphenopopliteal saphenofemoral junction and cocket perforated incompetence. So this was a case of a venous ulcer due to chronic venous insufficiency. So my question to Biju sir would be, sir, you discussed all about the clinical approach. What are the other investigations would you like to do before treating this particular case?
Yeah, so basically this this looks like a venous ulcer. Of course, from the side you can see the medial
Yes, sir.
portion involved, and you've also said that there is incompetence. So we all know the etiology to it. So basically, I don't think in this case too many because the venous ulcer, and you know it is a varicose, the incompetence of the veins which is responsible. So you need not do too many investigations. What you can basically look at is the ulcer size so that we measure it before so that we know how it improves. Then we basically look at this ulcer looks a bit clean, so you don't need too much of kind of dressings for the ulcer. Otherwise, you can use a non-adherent dressing for the ulcer. And then you basically look at how you can treat the basically incompetent veins. So that would go on to a surgical management, whether you want to do the latest available techniques, whether you want to take it up through the SEPs, that is the endoscopic way of treating the veins. So that would be more of a vascular surgical treatment, I think, for the etiology in this case.
Okay, sir. Sir, it is not pertaining to this particular case, but
Yeah.
in many cases, we have seen that venous ulcers are present where we get a normal color Doppler. A normal venous Doppler is present. Sir, how to approach such cases?
So you have a normal Doppler means the thrombosis is not there is one thing which we can rule out. Of course, we sometimes it can be mistakenly. I mean, we need to rule out the arterial ulcer. We do the ankle brachial pressure index. We also, since it's a venous ulcer, we have to give other measures like the elevation of the leg, the graded exercises, and one important part would be the compression therapy when it comes to the venous ulcers. So that is the cornerstone of treatment when it comes to venous ulcers. And if you have actually wounds, like you have highly exudative wounds, then you can go give a foam or an alginate dressing. If you feel that you have a very foul smelling kind of ulcer, then you can give a dressing with hydrocolloid. And basically, it has to be non-adherent dressing that when you take it out, the granulation tissue should not come out with it. Of course, moist is always preferred when it comes to the wound care.
Okay, sir. Sir, in case of an exudative wound, how do you go for the dressing and how do you allow the compression? Because compression is supposed to be the main therapy of venous ulcer.
Correct. So when it is a very infective wound, I would say the compression should not be applied on the wound, because that would not help the wound heal. So
Okay.
basically, the wound part of it you have to take care first. So if it is heavily infected, so as I said, if it is foul smelling, of course, send an antibiotic sensitivity, send a culture from this, take a swab. Then basically, if it is very copious discharge, then you give an alginate dressing or a foam dressing, so that the discharge is absorbed and it becomes a bit drier. If you feel it's a ulcer where it is very foul smelling, then you have to give the appropriate antibiotics and do a hydrocolloid dressing. And once it becomes drier, that is when the time you can take on your full compression therapy. Or because the compression will have to be applied from the lowermost portion of the leg to it has to be a high compression dressing which has to be there. So it would be always better if you take care of the infection and then apply the compression in such cases. Otherwise, if the wound is clean, you can start your compression on.
Sir, in this particular case, what kind of compression would you like to give?
Yeah, compression should always be 4-layer. That is how compression is basically you have the basically first the
Yes, sir.
gauze-based dressing,
Okay,
then
sir.
the, yeah. So the 4 layers of compression should be there, and it should be a high compression, that it should go above the knee. So at least
Okay.
up to the, yeah, at least up to the distal
And it should
third
be
of
a
the
graded
thigh.
one.
It
It
should
should
be
be a
a
graded
graded
one.
one. Yeah, it should be
Okay, sir.
graded compression.
And sir, what is your take on the compression stockings? Because not all the time we are able to do a 4-layer compression
Correct, correct.
therapy.
So wherever possible, especially if the patient is in a tertiary care center, we should go for 4-layer compression bandages. And they're
Okay.
like the Coban bandage is what is standard. So that is
Okay.
what is to be applied. But if
Okay.
not possible, the stockings, the problem is sometimes the size doesn't fit. It basically becomes the elasticity wears off very much. So, I mean, it doesn't sit tight in most of the cases. So, and
Okay.
once you wear it and take it off, the elasticity, meaning it becomes stretched out very fast. So you need a change of bandages also very early. So these are things which should be. So wherever possible, a 4-layer compression. Otherwise, if you have a stockinette, at least it should be a proper fit and of a proper
Okay.
height.
And is
That is
patient
important.
compliance also a problem with
Yes,
stocking?
very much, very much, very much.
Okay. Okay. And sir, what about the peri-wound care? What is the advice to the patient? Because those areas tend to get macerated. There is also concomitant venous eczema.
Okay. Somehow, okay, yeah. So basically, you should be very careful with your topical antibiotic, because some of them themselves cause sensitization, and you can have an allergic contact dermatitis that can worsen things. Especially, you should be careful when you're using soframycin. The fusidic acid and mupirocin are much lower when it comes to sensitization. So that's one thing I would say. Then other things is basically you try to keep the surrounding area as dry as possible. The wound should be moist, but the surrounding area should be dry. So that is one thing. If there's an associated eczema, then you can give a topical steroid. Emollient, very, very important when you are taking care of the peri-wound area.
Okay.
And
And
yeah, you're
sir,
asking
is
something?
there yes, sir. Is there any role of topical antibiotics? Like you said that topical antibiotics can cause a contact sensitivity. So
Yeah, so
why do we need to prescribe a topical antibiotic? If there is
yes,
infection, we
correct.
go
We
for
give
a,
an oral
culture
antibiotic
sensitivity
as,
and
yeah,
give the systemic antibiotic.
correct. So always systemic antibiotic is preferred unless you have a very small kind of, you feel mild infection. That
Okay.
too, I would say avoid soframycin as much as possible, because that causes sensitization a lot. So only if it is required, really use it. Otherwise, go to systemic antibiotics when there's infection.
Okay. Sir, another thing I would like to ask you is about the systemic therapy, because compression therapy we've talked about. We have talked
Yeah.
about how to take care of the wound as well.
Yeah.
So, what is your take on systemic therapies? Because there are so many systemic therapies available, and there is so many levels of evidence as well. Do you prefer systemic therapy, and where, and which one do you prefer?
Yeah, so when it comes to say the varicose, the venous kind of thing, Daflon is something which works. So that is
Okay.
prescribed by the, it's basically a flavonoid. So that is
Okay.
one thing which is found to help. Another
Okay.
thing, the pentoxifylline or the other kind of thing, there the evidence is, I know, is depending actually on the cause. So when it comes to a
Okay.
venous cause, I think taking care of the varicosity, very important if it's varicose veins, taking
Hmm.
care of
Okay.
the circulation. So the flavonoids does help.
Okay.
Antioxidants sometimes a role, sometimes they say the zinc and the aspirin may have a role. So those are things which may help. Another thing which we found that when you have you have varicose ulcers which are getting repeatedly infected, doxycycline as a modality for about 21 days is found to, we've been doing studies with our reconstructive and plastic vascular surgery colleagues. We found that doxycycline for 21 days does really well. Another thing which is easily available with us is honey. So if we have honey, which
Okay.
is kind of sterile, so that can be applied and it tends to make a lot of difference to not the ulcer area, I would say, the surrounding area. So that's some things which practically I can say helps.
Sir, have you have tried all of them? Which one do you find that helps the most? Which one do
First,
you prefer for your patients?
you're saying systemic therapy?
Yes, sir, for systemic therapy.
Systemic therapy, what I give the patients, of course, in addition to all the compression, the counseling, and the dressings, and the antibiotics. Systemic therapy, I do give Daflon when it is the varicose veins.
Okay.
That is something which I have picked up from the vascular surgeon.
Okay.
Then I do use locally, I do use honey for the lesions, not on the ulcers, but if there are any varicose and ulcers which can change into, the lesions which can change into ulcers. And some I do use oral zinc in a few patients. So these are things which have been generally I find useful in my practice.
And for sir, how long do you use them?
Yeah, now that's a big question mark because that depends on how fast the ulcer heals actually.
Okay, sir.
So yeah, so basically the Daflon we give about for 3 months at least
Okay.
minimum, and same with oral zinc.
Okay.
And the honey, of course, is only required if there's any surface changes on the skin. So that depends. Once that heals, then I take it.
Sir, you also talked about thrombotic episodes when I talked about like the Doppler was within normal limits.
Yeah.
So, how to proceed in such cases?
You mean when there is a thrombosis suspected?
Yes, sir. From a
So
thrombotic
of course,
perspective.
when there's a thrombotic episode suspected, of course, one is whether we're dealing with the livedoid vasculopathy. That's
Yes,
a
sir.
common cause of ulcers.
Absolutely,
So
sir.
yeah, then you need to look at whether it is APLA
Okay.
and any of the other. So basically, then you need to do a prothrombotic screen, the
Okay.
prothrombin, PT, PTTK,
Okay.
the tetrahydrate folate reductase inhibitor, the prothrombin gene mutation, protein C, protein S. So
All
the
the coagulopathies that need
yeah,
to be
all
ruled
the
out.
coagulopathies,
Okay,
because
sir.
then you'll have to find a cause for it if it's a
So,
coagulopathy.
is there any particular clinical pointer which would say that this is a thrombotic episode, not a venous episode?
Yeah, of course, once the thrombotic ulcer is there, the location is usually not the gator area, though the thrombosis also can
Sir,
usually
it
come.
always does not present in a
It
very
always does
classical.
not, correct. It's
Yes, sir.
very difficult to distinguish. But if you have a livedoid vasculopathy, maybe you get a livedo around it. The
Okay.
ulcers are going to be really painful
Okay.
when it comes to a vasculopathy. Usually, a thrombotic is much more painful than a venous ulcer. Venous ulcer is usually not painful, and there'll be much more oozing from a venous ulcer. That's another thing. There's other
Okay.
pointers.
Okay. Okay.
And of course, if there is a thrombosis or a vasculopathy, it usually gives other features, associated symptoms. Like there may be a livedo, there may be extreme pain, then
Okay.
other features associated with the syndromes may be there. Like with an APLA, you have an SLE associated. So something like
Of
that.
course, sir.
So much
Okay, sir.
more symptoms when you have to look for as a
We
cause
have to go
other
for the
than a
systemic
venous.
symptoms also. We need
Yes.
to
Yeah.
take the patient as a comprehensive person and
Yes. Yes.
look into every
Sure.
possibility.
Yes.
Okay. Thank you so much, sir. Thank you so much.
Okay. Thank you. And
Okay.
thank you, everybody. I'll be leaving the session because I have something to attend. Thanks,
Okay,
everybody.
sir. Okay, sir. Thank you so
Thank
much,
you
sir.
so
Thank you
much.
for being on the panel.
Thank you.
Okay, so we move on with our panel. Biju sir has to leave early. So Shumit sir, are you there?
Yes, I'm.
Yes, sir. Sir, I would also like to ask you about the systemic therapy because it seems like there are so many various levels of evidence for certain things, and the systemic therapy varies. Uh,
I would like to point out a few things that
okay,
in
sir.
the case you have shown.
Yes,
The
sir.
first thing, at least I would like to do, is to find out if there is any arterial component.
Exactly, sir.
So
Okay, sir. Okay,
I
sir.
would at least go ahead with the ABPI. That is, to find out if there is any sort of arterial.
Any sort of arterial insufficiency. Definitely, sir.
Compression therapy is a mainstay
Okay,
of
sir.
managing of venous ulcers. Now, coming back to your question, yes, there is a role of pentoxyphylline for in this sort of ulcers, and that can not only heal the wound but can also give the patient comfort. And regarding doxycycline, I want to point out it is a unique drug because it's an antibiotic, but it has also got angiogenic properties. So yes, it can be given. And in this sort of the case you have shown, I see there is absolutely no indication for any systemic, at least antibiotic, because this
Yes,
is
sir.
a healthy wound. And in fact, there is no indication absolutely for any topical antibiotic also. So what it needs is a proper, just a proper moist dressing, not too moist, not too dry. The balance should be kept. The margins of the ulcer should be taken care of with some sort of protection. And
Okay, sir.
then we should go ahead with compression bandages. And if only it is necessary, then we should think about systemic therapy.
Okay, sir. And sir, there is also in this case lipodermatosclerosis is
Yes.
present in as in many cases. So, what would you like to prescribe for that? Because lipodermatosclerosis is causes a lot of
Yes.
quality
Actually,
of life compromise in the patient.
actually, you see, lipodermatosclerosis, it is very difficult to heal. But let me point out, there has been in our very textbook of Bologna, and I would also request our students and many of our teachers also, they can try out retinoic acid. Retinoic acid 0.025% has been shown to be effective in leg ulcers and also in treating these sort of ulcers and in the healing of ulcers.
No, sir, but I'm asking specifically about the lipodermatosclerosis.
Yes, it has been shown also to be effective in lipodermatosclerosis, but
Okay,
once
sir.
lipodermatosclerosis sets in, the prognosis, of course, is not very good, and compression bandage has to go on, has to
Sir,
be.
what is the, I'm interrupting you, sir, sorry. Sir, what is the role of stanozolol in this case?
Flavonoids, yes, there is some role. I have not tried as a routine this thing. So my experience in this particular, with this particular drug is limited.
Okay.
Whatever it is there in the textbooks, that is that much I can say. I have no personal
Okay, sir.
experience with
Okay,
this
sir.
sort of
Okay, sir.
flavonoid in leg
Okay,
ulcers.
sir. Okay, sir. Siddhartha, sir, have you tried stanozolol in such cases? Uh, hello? Sir, we can't hear you, sir.
I think he has to unmute himself.
Sir, kindly no, he has unmuted himself.
Now, are you able to listen to me?
Sir, a little louder, please. A little louder, please, sir.
Are you listening me now? Are you able to listen me now?
Sir, there is, sir, I'm not able to hear you properly, sir. Hello?
Now listening to me? Listening to me?
Yes, sir, we can hear you now. Just a little louder, please, sir.
Okay, fine. So basically, when you go for a leg ulcer, so most of the ulcers are venous ulcer, and you have to take care of the ulcer part at the same time. So lipodermatosclerosis part. So what I'll be looking for in this case, Dr. Singh has rightly pointed out, you don't need to go for much of antibiotics. Even doxycycline has got some antiogenic effect, so you can go for that. And then also, like for lipodermatosclerosis, yes, what I prefer normally, I always prefer to go for some, antibiotic with steroid, with conventional antibiotic, and that's how it very nicely. And at the same time, also I like to go for emollients also.
Okay, sir. And sir, am I audible to you?
Yes,
Okay, sir. Sir, how do you prefer to give a compression therapy?
compression therapy is really effective. I suppose if the ulcer is very much used, I think I'll go for 4 layer. Otherwise, it's really very, very difficult because when you, it's very difficult to take a stopping. It's very difficult to wear, and at the same time, also when you remove it, and that is also very difficult.
Okay, sir.
So always go for like either 4 layer or 3 layer. So basically, I'll go for a first like a gelonate, then go for watch piece, and then micropore, and then also sometimes I'll go.
Audrija, do summarize what Siddhartha is saying because many can't hear. Just summarize what he said.
Sir also prefers whatever has been said before. It's sir also prefers to give a 4 layer of graded compression. And sir, I also would like to ask all. I mean, this is a question for Siddhartha sir as well as Anupam sir. Like when to refer the patient, because there is a limit to which a dermatologist can. To a limit to which we can treat the patient. So when do we refer the patient?
Number one more thing. Normally, most of the ulcer it takes 4 to 6 months here. If it's beyond 6 months, then there are two options. Because if you are a cosmetic dermatologist, try for you can go for TRP or platelet rich platelet rich plasma also is very, and platelet rich fibrin is also another effective. There is a very good.
Sir, I'm having difficulties.
Go for grafting.
Okay.
Audrija, may I say
I
something?
yes, sir, I would like to move on to Dr. Anupam Dash. Sir, how do you? I mean, when do you refer a patient, and for what reasons? What are the indications for a surgery in such a case?
Yeah. Thank you. First of all, thank you, Audrija, Shumit sir, and all the organizers for this opportunity. So coming to the question, when to refer the patient, I think there is no specific guideline regarding the referral, because if we be very honest, once we refer the patient, say to a vascular surgeon or say a surgeon, the patient is not going to come back to us. So that is a frank issue which we face. But yes, if there is no improvement, as Siddhartha sir said, if there is no improvement in the healing of the ulcer or in the, there is no improvement regarding the granulation tissue or whatever, I wait for maximum 3 to 4 months. If within 3 to 4 months I don't find any clinical improvement, I would prefer to refer. Apart from that, if there is any concomitant arterial component, I would also think I should refer the case. These are two important things.
Okay. Thank you. Thank you, Anupam sir. So there are few guidelines. I would just glance through them since we do not have much time. Compression therapy is the first treatment of choice, and compression can also help prevent the recurrences as well. So there was this summary of recommendations, the Indian recommendations, where it is also said that we need to rule out arterial ulcer first. We need to do an ABPI and compression therapy for treatment as well as for recurrences. And as sirs had already mentioned, that bacteriological swabbing and just empirically antibiotic giving is not recommended. And pentoxifylline usually has a high level of evidence as an adjunct to compression therapy. So this is my next case. He was a 32-year-old mason. He had a painful ulcer since the last 2 weeks. There was a history of previous ulceration in the great toe, as well as history of heavy smoking, 2 to 3 packets of bidi per day. The arteria dorsalis pedis was not palpable. However, the arterial and venous Doppler were within normal limits. Anupam sir, what is the next best step in this case?
Yes. So as evident from your history and clinical photograph, it's a frank case of arterial ulcer.
Exactly.
So the first advice to the patient has to be bidi chhod do. So that is the first thing which has to be done, bidi chhod do.
Bidi chhod do.
Bidi chhod do. So I don't think patient will follow the advice. So at my end,
we say that he bidi chhod diya. What is the next step?
Bidi chhod diya, fine. Bidi chhod diya. Then apart
from that,
good
girl. He's a very good boy, and bidi chhod diya.
Okay, lucky doctor. Then fine. Then the next best thing is you have to take care of the comorbidities which are associated. Whether the patient is overweight, weight loss has to be advised. That is very important. Whether there is any systemic hypertension, that needs to be taken care of. Whether the patient is having diabetes, that needs to be taken care of. Hypercholesterolemia, LDL cholesterol, we need to use statins, those need to be taken care of. And very importantly, I think I will go for antiplatelet drugs. But at the same time, since it's an arterial ulcer, I am not much comfortable in handling a case of arterial ulcer alone. I would rope in a vascular surgeon.
Okay, okay. Shumit sir?
Yeah, I agree fully with Anupam. The first step is that this I want to say that this is a team effort. These sort of ulcers should and the team should include even an orthopedician, a chiropodist, and also preferably a vascular surgeon, of course, a dermatologist. And next, of course, complete history should be taken. Even though you have mentioned that smoking, the person is a smoker, but there are other things in the history. The long history should be taken. Cardiovascular status, and what about diabetes? Is the was the patient diabetic? Have you mentioned?
So this
Because
person
many
was
we
not a
know that
diabetic.
many. Okay. So these things I would like to ask, and then of course after taking a comprehensive history, I would try, I would like to form a team, because as this management of such an ulcer is a teamwork where a dermatologist perhaps will form has a very small role. And just I
Okay, sir.
want to say that it needs this needs of course the offloading of his and should avoid any loading of the part, and other the ulcers should be free of any load.
Okay, sir. Okay, sir. They should be free of any load. So, how about mixed ulcers? Because it is not so common in our practice, but do you get mixed ulcers? How common are they? Shumit sir?
Of course, in our country, I think, sorry, I'm very sorry.
Sir, I would
Yeah,
go to Dr.
just
Tanushri ma'am then. Uh, Tanushri ma'am, how frequently do you see mixed ulcers? Ma'am, please unmute yourself. You're not audible.
okay. Audrija, can I go ahead? Because
Yes, sir. Yes, sir. Please, sir.
I think
Please,
it's
sir.
having some
Yes,
problems.
sir.
So, of course, over here, yes, first of all, yes, we do get mixed ulcers. Perhaps we are missing many of them. We should diligently look for the arterial component, even in a venous ulcer, number one. So, proper history and proper examination should be taken. Just limb. Very simple clinical examinations like limb elevation and then the ABPI. These can be measured even in the OPD or in a person's chamber. And
Okay.
once it is established that there is an arterial component, this aspect should be taken care of first of all. But
Okay.
let me tell you that because the venous ulcers need, the mainstay is compression therapy, and if we go for a very tough compression therapy with an arterial component, then obviously it will be detrimental to the wound.
Yes, sir. Okay. Tanushri ma'am, do you come across mixed ulcers, both venous and arterial component? Ma'am, we are not able to hear you. I think you might be having some technical issues. I'll ask the technical team to contact you. So we had a go with venous and arterial ulcers. I would quickly move on to the third case. This is a trophic ulcer. There is no doubt about it. And he had, so this was a 40-year-old gentleman. This is a painless ulcer, had completed multi-drug therapy for Hansen a few months back. So how to treat him? How do you treat him? Tanushri ma'am.
Hello, can
Hello.
you hear
Yes, ma'am.
me?
You're audible now. Yes, ma'am. You're
ma'am.
audible
Yes,
now.
ma'am.
Okay.
Yes, ma'am. Okay. So how do you treat this patient with a trophic ulcer? Post MDT trophic ulcer.
In case of trophic ulcer, first of all, we check there is any evidence of infection or not. According to that, we prescribe antibiotic, and the antibiotic systemic antibiotic should be given according to the culture sensitivity report. And along with that, topical antibiotics are given But and when the ulcers are start to healing, at that point we take care of offloading, because even if the ulcer, a trophic ulcer, completely healed, even after complete healing, there is a chances of recurrence of ulcer within 2 months if there was not proper offloading is done. Offloading can be done initially by pairing the edges of the ulcer, particularly the callus, dead tissue, and hyperkeratotic tissue are removed completely. After that, we can prescribe a walking cast with a window. Through that window, we can take care of the ulcer. When the ulcer is completely healed, in that condition, specialized shoe made of microcellular rubber was advised. And if there was a patient suffering from clogged toe, or there is any other deformity that causes inadequate pressure distribution or inadequate pressure distribution, in that case, we can also refer the patient to the rehabilitation surgeon. They can perform either tendinectomy, or occasionally they do corrective bone surgery that can reduce the pressure when the patient walk. In this way, we can offload, and if we maintain this offloading for long period, the recurrence of the ulcer being
So
minimal.
the mainstay is offloading of the pressure, be it in a cast form or in specialized shoes, or we can also do some surgical procedures.
Surgeon.
Okay, and if
And
the
I
ulcer
just,
is not healing, if the ulcer is
Aditya,
not healing,
and
yes,
Aditya,
sir.
I just want to make a point that total compression casting TCC is perhaps the most effective, though the most uncomfortable one. It is the
Okay.
most effective for offloading purposes.
Okay, sir.
For the-
Okay, sir.
Sir,
The total cast. Okay.
Sir, I want to say something. If the ulcer is not completely healed, ulcer is on healing process, then dressing of the ulcer is a necessary thing or mandatory thing. For that, we make a complete contact cast with a window. That window was over the ulcerated area.
Yes, yes.
From that
Yes, yes.
window, we can dress the ulcer regularly.
Absolutely.
So,
absolutely.
is it required to dress the wound regularly if it is a clean cut wound, which we usually find in a case of Hansen? If it is a diabetic ulcer, we could have kept a window dressing or such like that, because it tends to get a very dirty wound. In case of
No.
a Hansen ulcer, if it is a chronic ulcer, it is not an active ulcer with not much exudate. What needs to be done?
No, you need a window because you need to inspect the wound regularly also. Even if it is not infected or you don't want to dress it regularly, you have to inspect the wound regularly. So you need a window.
So
a
how
TCC
long
with
should
a
we
window-
allow? How long should we allow the cast to remain, and how long should we allow the ulcer to heal by itself?
As I said, this is a very uncomfortable. The TCC is a very uncomfortable, but it is perhaps the most efficient one.
Efficient,
So
yes, sir.
if you can put it, even if the person can put it on for 3 weeks, then you will see
Okay.
that the ulcer is healing definitely. And as Tanusi has rightly pointed out, if you just put a window and you can just examine the ulcer, if, say once in
Regularly.
2 or 3 days, then you will
Okay.
be able to judge the results.
Okay, sir. Okay, sir. Thank you. That was a good one. And sir, say it has healed. So after that, what should be the? The patient cannot be on a cast for a very long time. So what other measures do you prescribe for lifelong? To the patient, because he has anesthesia, he has inadequate and unequal distribution of pressure over his feet, so there are high chances of recurrence. So how do you suggest, what do you practically suggest to the patient?
Who's this question for?
Sir, this is a question for you, sir.
Dr. Das.
So not
Okay,
for
so,
sir, for you,
of
sir.
course, of course, first of all, the person should be educated and informed that what is the cause of that ulcer. Next, he should be taught to take short, small steps. Next, he should be taught to inspect his ulcer every night. And if he finds that there is any chance of there is any pus coming out or any signs of inflammation, he should report this to his doctor immediately. And these are the things which he should continue.
Okay, sir.
throughout his treatment period.
And sir, actually we are running quite short of time. I'd like to ask you about something, that is, what about PRP or PRF therapies? Because we are doing it in our center, and this is a case of a trophic ulcer. After 3 sessions of PRF, the ulcer has healed quite like this. But of course, even if we do not give offloading, then it will again revert back. This first 6 to 8 weeks is very critical. So what is your take on
Yes,
PRP or
of
PRF?
course,
Tanushri ma'am,
there
would you like to take this up?
Actually, I do not have doing any PRF on this type of trophic ulcer, but I do PRP therapy in trophic ulcers of Hansen's disease, and I have got a very good result. After complete healing of the ulcer, initial first 2 months is very critical period, and offloading is maintained for that period. If patient is able to maintain the offloading, the chances of recurrence is very low. And
Madam, how many sessions of PRP do you use?
usually I need 3 to 4 sessions of PRP. If the ulcer is not very much deep, it will take 2 to 3 sessions. If the ulcer is very deep, in that case, it will take 4 to 5 sessions.
Okay, since we are very short of time, I will just go through this case. This will be the last one. He's a diabetic, uncontrolled diabetic with a hemoglobin A1C of 8.4. This is a very shallow ulcer, and he has pain, swelling, and erythema. So how do you treat such a case? Dr. Dash, are you there? Dr. Siddhartha Dash, sir, are you there? Okay, sir is probably has some technical issues. Anupam sir, how would you treat this case? How long would you allow the ulcer to remain before it heals?
Since this is a diabetic ulcer only, so so far as treating this case is concerned, yes, I would go for a daily saline dressing.
Okay.
Debridement, I cannot see properly.
Debridement is not necessary in such case. There is not much of a slough.
Okay.
Okay. Actually, let me reframe my question. The thing is, we would probably do a culture sensitivity, give antibiotics. The symptoms would resolve. But there is a problem of pedal edema that remains after resolution of symptoms, and it causes quite a cause of discomfort to the patient. So, how do you tackle that?
I think the underlying diabetes has to be taken care of.
Okay. And from your end, what do you do?
I don't think anything apart from the saline dressing or something.
Okay. Shumit sir, would you like to do anything different?
Yes, no. I think I want to stress that most important is the glycemic control. He's having a
exactly, sir.
8.4 or something. Yes, if he continues with that, and of course, this is a clean wound. So saline, first of all, just saline dressing will be saline cleansing is sufficient. And in case it worsens, then we can go for some autolytic debridement with hydrogels. That is the thing.
Okay.
And if you are asking for any specific treatment, actually, there is nowadays, of course, the role of hyperbaric oxygen, systemic hyperbaric oxygen, and all. But these are we don't get to do these in our center. So, and there are some other acellular bioproducts, acellular dermal matrix, and all those things.
Yes,
these I have read in theoretically.
Yes,
I have not been able to practice. Of course, there are role of human growth factors also, fibroblastic growth factors also, epidermal growth factors, vascular endothelial growth factors, all these things, and of course platelet derived factor. Now, and also,
sir, is that available in our country, platelet derived growth factor?
That's what I said right in the beginning, that these are not available. These are all the things. So what I suppose what
yes, sir.
Okay, sir. So
as sir already mentioned, Becaplermin gel, Apligraph, all those things. All these things we have read in textbooks only.
We have theoretically only.
Exactly. I don't have any experience.
Yes, ma'am. Becaplerine has a black box warning. Becaplerine has a black box warning. It is carcinogenic. Please remember. Becaplerine has a 43% rate of healing, but it has got a black box warning also.
Malignancy.
A lot of talk about Becaplerine.
So probably
Adrija?
in the next conference, we will have to do that. We are already running up very late.
Adrija,
Yes, ma'am. Yes, ma'am.
I want to say something
Yes, sir.
because in case of uncontrolled diabetes mellitus, there is these uncontrolled diabetes mellitus cause this type of ulcer due to damage of the microvasculature. So we can add an antioxidant,
Okay.
which can reverse that
Okay, sir.
process of
Okay, ma'am. Okay.
microvasculature damage to some extent, and can also helps in faster recovery of the ulcer. And at the same time, the scenario of this case, I must refer the patient to endocrinologist to control the diabetes mellitus.
Okay. Okay. So to summarize, venous ulcers, we need to treat for a long time, at least three to 4 months before we refer to a surgeon for surgical intervention. Compression therapy is our mainstay of treatment. We do not need to give antibiotics regularly. Compression is also required for to prevent recurrences. For arterial ulcers, we do an ABPI. We mostly refer it to a vascular surgeon. For neuropathic ulcers, offloading is the mainstay of the treatment. We need to take care of the wound. A total cast would be with a window dressing would probably be the best option in such a case, and we should allow at least 2 months for the ulcer to heal. We may also, after that, even if it doesn't heal, we may go for growth factors in the form of platelet-rich plasma or platelet-rich fibrin. And in case of diabetic ulcers, the glycemic control is of prime importance, and we also need to look out for any arterial arterial component or other systemic components in it. And also antioxidants can also help, even in case of venous ulcers also. So that was it for today's panel. I would like to thank all my panelists. Thank you for being there, and thank you the organizing committee. Thank you so much. I end my session here.
Thank you, madam.